Very good evening, and thanks to everyone for joining us today. I, Ankit Dogra, along with my teammates Dr. Deepika Chhabra and Mr. Amit Saxena from Medical Services and Mr. Rohit Kumar, Area Sales Manager from the Naari Division, Jagsonpal Pharmaceuticals Ltd. Welcome you all to today's webinar on IUI, the methodology and indications with pharmacokinetics of male infertility, an initiative by the Indian Fertility Society, Haryana, with Lalita Memorial Hospital, Rewari, supported by Rewari Obs Gyn Society. The academic partner for today's program is Jagsonpal Pharmaceuticals Ltd, makers of PRORETRO, 10 mg tablets of indigenous and affordable micronized dydrogesterone, assisting motherhood, delivering happiness, along with Cystelia M, formulated with the ideal 40:1 ratio of myo-inositol and D-chiroinositol with folate and vitamin D3 to enhance the fertility outcomes, and Endoreg 2 mg tablets of Dydrogest for the medical management of endometriosis and endometriosis associated pelvic pain. We extend a warm and hearty welcome to all the esteemed speakers, experts, and the attendees. Dear attendees, we request you to post your thoughts and opinion by text in the Q&A box. Please note this webinar is streaming live on the Facebook and the link has been shared in the chat box. To refer to this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights, as its complete recording will be uploaded there. Now we welcome and request the convener of program, Dr. Seema Mittal, Director, Lalita Memorial Hospital and Infertility Center, Rewari, and Treasurer, Indian Fertility Society, Haryana chapter, to kindly initiate the proceedings. Over to you, ma'am.
Thank you, Ankit ji. Good afternoon, friends, and welcome to this very interesting webinar of today's evening. Why this topic? Male infertility is a subject where more we know, lesser it is. Whatever the studies we have are retrospective. There are no comparative studies. There is no consensus. So today evening, with all our worthy chairpersons and speakers, I'm sure we are going to formulate some guidelines which will simplify the treatment and justify the IUI steps and protocols. Friends, it's pleasure to have Dr. K.D. Nair sir, President IFS, for the next session. And I'm very, very sure that we will have beautiful innings with him. And under his guidance, there is so much to learn. I request our chapter secretary from Haryana, Dr. Sonu Balahara, to welcome sir and all the attendees and the participants for this webinar. Over to you, Dr. Sonu.
Thank you, Seema. Good evening, everyone. I welcome you all to this webinar on male infertility. And without wasting time, I welcome our dynamic new coming president, Dr. K.D. Nair sir, to say a few words. And he is taking charge from Dr. Sudha. So, and we hope to achieve new heights for our society under sir's guidance. Sir, kindly say a few words.
Good evening, ladies and gentlemen. Let me to congratulate IFS Haryana chapter led by Dr. Sonu Balahara and Dr. Seema Mittal for being in the forefront of the academic activities like this webinar. And that is what we are going to look forward in the next 2 years. We have a lot of academic activities and in the process maybe to come up with 1 or 2 guidelines also. And we are looking to have a multi-centric trials also so that we can have some data collection and publish it. That is what we have been lacking till now, that we are not, we don't have our own data. So we are going to start the data collection also from various centers all over India, and we are going to publish it. Again, to congratulate the IFS Haryana chapter, we have been always in the forefront of academic activity. My congratulations to all of you and the delegates who are logged in for this webinar. Thank you very much.
Thank you, sir. We look forward to all your blessings and guidance in future as well. And definitely we promise you that we are going to work hard with you to learn more about infertility. And now we have the chairpersons for the most wonderful session, Dr. Sunita Chandra, Dr. Surekha Yadav, she is our very own president of Rewari Obs Gyn Society. The much talented Dr. Surekha Yadav has special interest in gynae surgery, and she has to accredit more than 10,000 NDVH in 15 years of private practice. We have Dr. Sunita Chandra. She is chapter secretary UP, and as you can see from her CV, she has so many papers and achievement and awards to her credit, and she has been honored with Gomti Gaurav Awards, Sanjogta Mahajan Memorial Award, Samman Patra, and I think there are many more yet to come. So I will request Dr. Sunita to introduce the guest speaker, our very own Dr. Sanu Balhara, for the evening.
A very good evening to all of you, and thank you Haryana chapter, thank you Rewari Society, and thank you my dear friend Sonu for giving me this opportunity to introduce none other than a very dear friend Sonu for this talk. So actually you people have taken a very good topic, male infertility and IUI, because male infertility, as you said, the more you know, the more you are in dilemma what to do, what not to do. So let's hear from Dr. Sonu what she is going to say about male treatment options. She is in charge and unit head, reproductive medicine unit, Artemis Hospital, Gurgaon. She is a dear friend, and I mean, uski jitni tareef kare utna kam hai. She is very nice, and of course full of knowledge and very hardworking and doing wonders in Haryana chapter of IFS. Actually, IFS as such gives so much to learn and so much to work that everybody wants to work under guidance of our secretary and president, whether it was Dr. Sudha Prasad or Dr. KD Nair sir, who is coming next. All of them are really very good. Because they are good, that is why we are working under them. So without wasting time, I think Dr. Sonu can go ahead with our talk on male infertility options. Let us hear from her, and let's take some takeaway points from her talk. Thank you so much.
Thank you, Dr. Sunita. And very rightly said, IFS is really, it gives us the opportunity to bring out the best in us. And I have learned so much from you regarding our chapters and how to conduct everything here. So thank you so much. Male infertility is actually a very neglected, we gynecologists, we don't much treat the male. So if there is a problem, we always refer them to the endocrinologist or the urologist. But we took this opportunity and I don't know if I can really do justice to the topic, but it's a very short presentation. We will have more elaborate ones in the coming sessions. So coming to only the treatment options for male infertility today. So male infertility is failure to conceive within 12 months of attempted conception. Just a minute. Is due in whole or in part to the male in approximately 1/2 of all the infertile couples. Although many couples can achieve a pregnancy with ART, evaluation of the male is important to identify the conditions that may be medically important, counsel men regarding their future health, and to most appropriately direct therapy. Most male factor conditions are specifically, they are treatable with medical or surgical therapy, while others may only be managed with donor sperm or adoption. So male infertility is mostly due to low sperm production, abnormal sperm function, blockage, illness, injury, chronic health problems, and lifestyle choices. So the treatment options in male infertility depend on the underlying cause. So initial semen analysis is very important, and reproductive history. These two things are very important. In the reproductive history of the male, we have to assess the functional, sexual, lifestyle, and medical history, including medications that can contribute to reduced fertility or sterility. Semen analysis is a very important component, and it actually directs us to the treatment. So semen parameter values falling above or below the lower limit, they do not by themselves predict either fertility or infertility in the male. These parameters are highly variable biological measures, and these may vary substantially from ejaculate to ejaculate. Therefore, at least 2 semen analyses, ideally obtained at least 1 month apart, are important, especially if the first semen analysis was abnormal. So, as I said, treatment is based on the underlying cause, or in the case of no identified problem, evidence-based treatment that improve fertility may be recommended. So that treatment may be surgical treatment or medical, or if we for pregnancy, ART. So in the surgical treatment, to correct or repair the anatomic abnormalities or damage to the reproductive organs, surgery can be effective for repairing the block in the tubes and also for repair of varicocele. Medication can treat some issues that affect male fertility, including hormone imbalance and erectile dysfunction. So treatment based on semen analysis, each and every parameter of semen analysis gives us very important information. So coming to the volume, normal we know is 1.5 to 4 ml. So if there is no semen, it is aspermia. If it is less than 0.5 ml, it is hyperspermia. So here there may be ejaculatory duct obstruction, seminal or vas malformations. There may be congenital absence of the vas or the seminal vesicles. Here fructose is also absent, or there may be retrograde ejaculation. The hyperspermia is when it is more than 6 ml, and it can lead to sperm dilution. The color is usually homogeneous and or gray. If there is blood, that is hematospermia, so infection, inflammation, tumor, polyp, obstruction, prostate infection may be there. If the pH is more than 8, it may be prostatitis, vesiculitis, bilateral epididymitis. If it is less, there may be chronic infection or obstruction of the ejaculatory duct. So here, now coming to when the volume is low, there may be retrograde ejaculation. So, So here, retrograde ejaculation may be due to certain medical conditions like Parkinsonism, multiple sclerosis, diabetes mellitus, enlarged prostate, or it may be due to spinal injury. So here we have to collect the post-orgasm urine sample and process it for sperm retrieval. So the catch is that we have to alkalinize the urine, and then so that there is no damage to the sperms. So usually if we have to collect the urine, 2 days prior to that, we alkalinize the urine. Then on the morning when the semen is required, we ask the patient to empty the bladder, then ejaculate, and then again the urine is collected, and then it is centrifuged and the semen is analyzed. So here in retrograde ejaculation, it may be treated by symptomimetics and alkalinization of the urine with or without urethral catheterization. So there may be partial retrograde ejaculation also, which may exist concurrently with partial antegrade ejaculation. So if the antegrade specimen is sufficient for reproduction, either naturally or with medical assistance, no treatment may be necessary. However, if the antegrade ejaculate is poor and a substantial retrograde ejaculation is present, as demonstrated by post-ejaculatory urine analysis, various therapies may be required. Many men with lack of emission associated with spinal cord injury or psychogenic anejaculation may also respond to penile vibratory therapy. For men with persistent lack of emission despite medical therapy, electroejaculation or surgical sperm retrieval may be employed based on severity, clinical presentation, and response to other less invasive therapy. So in these patients, this ejaculate may be used for IUI or if we are doing other ART procedures. Then coming to leukocytospermia, men with true pyospermia, that is more than 1 million leukocytes per ml, they should be specifically evaluated to exclude genital tract infection. Leukocytospermia leads to radical oxygen, free radicals, which lead to DNA fragmentation and reduced sperm motility. It is an important cause of OATS, hence it needs to be treated. Usually doxycycline, amikacin, azithromycin, or quinolones are given to the patient. Results of the treatment are very satisfactory, and these lead to increased sperm count and motility. Here, this antibiotic therapy may also be combined with antioxidant therapy, which are quite useful in these kind of patients. So in the antioxidants, usually vitamin C and high doses of vitamin E are quite effective. Now coming to treatment in cases of varicocele. So here, this is the examination. Evaluation includes medical and reproductive history, physical examination, and at least 2 semen analysis in these patients. On physical examination can be done both in recumbent and upright position. So treatment should be only larger varicoceles which are easily palpable. They are known to be associated with infertility. Therefore, ultrasound, Doppler, spermatic venography should not be used for the detection of subclinical varicoceles in patients without a palpable abnormality. So this is very important, that where the varicocele has to be treated. So the varicocele which is palpable on physical examination and not by ultrasound or Doppler, where the couple has known infertility, the female is normal or has potentially treatable cause of infertility, and the male partner has abnormal semen parameters. So only these varicoceles are to be treated. So here all the parameters, all these 4 should be met, and no varicocele repair should be done if the normal semen, if there is normal semen with clinically palpable varicocele. So even if there is a palpable varicocele, but the semen is normal, it should not be repaired. When there is abnormal semen parameter with clinically non-palpable varicocele detected solely on imaging. So here also there is no indication to surgically repair the varicocele. Or if there is non-obstructive azoospermia with varicocele, idiopathic semen abnormality, or in these couples where IVF is indicated with the aim being to improve the semen parameters for IVF standards. So here also no repair should be done. So this slide is very important, where we should treat the varicocele and where there is no benefit of treating the varicocele. Now coming to immunological infertility. So when anti-sperm antibodies, they form when there is a breach in the blood-testis barrier, which may be due to trauma, torsion, biopsy, orchitis, and vasectomy. Sperm-bound antibodies, they can decrease the motility, they block penetration of the cervical mucus, and prevent fertilization and decrease the likelihood of conception. There is high prevalence of asthenozoospermia with normal count, unexplained infertility, and the semen with very high agglutination. So here in these cases, treatment is with steroids. Sperm washing can also be done. This is quite rare. Now coming to medical therapy, I will skip this slide, but this is quite important, that mostly hypo patients where the FSH, LH, testosterone all are low, these patients are more amicable to medical therapy. So treatment with gonadotropins, which is FDA approved. This is the only class of medication approved by FDA for medical management of male factor infertility. These include GnRH, LH, FSH, which are used to treat hypogonadism and hyperspermatogenesis. So the current treatment option include direct stimulation of the anterior pituitary using pulsatile GnRH or exogenous replacement of LH and FSH. So usually these patients we refer to the endocrinologist, but I have made 2 slides, so I hope. So here pulse GnRH therapy uses a pump to administer 25 to 600 nanogram per kg every 2 hours with an adequate response, usually taking 1 to 3 years. So it is quite a long treatment. Success with the replacement is more likely in a post-pubertal male without a history of cryptorchidism. Now, this is not available in the United States also and here also. Development of hypo before or after puberty defines the initial gonadotropic replacement regimen. So if hypogonadism occurs after puberty, the Sertoli cells have already been primed by FSH, and the gonadotrophin replacement may require only HCG, which is an LH analog. But on the other hand, if it is pre-pubertal, it will require both FSH and LH replacement, that is at least initially. So after priming with both FSH and LH, ongoing spermatogenesis and testosterone production usually only requires LH or HCG replacement. HCG has a biological activity of LH. Recombinant LH is also available, but its short half-life limits its utility. So HCG can be given intramuscularly or subcutaneously 3 times per week, starting with an initial dose of 1000 units. If the targeted testosterone is not obtained after 2 months of therapy, so we increase the HCG dose by 50%. So it can be 2000 or 5000 units. Moreover, if adequate spermatogenesis is not achieved after 18 months of HCG exposure, consider adding FSH also. There are several reasons to try HCG replacement therapy as it alone before adding FSH, because HCG is quite cost effective. It will increase intratesticular testosterone concentration up to 100 times that of peripheral blood, and HCG alone may be all that is needed to prompt spermatogenesis. So HCG is the drug of choice here. Now for FSH replacement, consider starting with 150 units every other day for the first 6 months, then increase the dose by 75 if no sperms are present, followed by a second dose escalation at 12 months. So escalation is done by 75 units. Recovery of spermatogenesis may be further enhanced by adding clomiphene citrate before FSH administration. HMG, it contains purified extracts of both FSH and LH. Again, the FSH component may be needed to initiate spermatogenesis in a male with prepubertal hypogonadism. So consider starting with 75 units, 1 vial of HMG 3 times a week, increasing the dose by to 150 if sperm concentration is not adequate by 6 months. So once sperm is present, consider discontinuing the expensive HMG while continuing HCG to maintain spermatogenesis. So this is just a summary of what I have already said. So in non-responders, HCG and HMG or pure FSH is given. So this is almost also the same. In hypergonadotrophic hypogonadism patients, insemination, we have no other choice but insemination with donor sperm or IVF-ICSI after preliminary genetic evaluation. So here mention about the erectile dysfunction where sildenafil can be used 25 to 50 milligram half an hour before intercourse. So we have already covered this. Now coming to treatment options in cases of azoospermia. So here diagnostic testicular biopsy for prognostic purposes alone, I want to highlight this point that it should not be done alone, and wherever possible a biopsy should be done where we have the facility of cryopreservation, so that we can, if we find sperms, we can cryopreserve them. This is the report. I just wanted to mention that it can be normal testicular tissue, early and late maturation arrest, germinal aplasia of hypospermatogenesis. So we will skip this. This is about the diagnosis. Now coming to sperm retrieval techniques. In obstructive azoospermia, we can do a percutaneous epididymal sperm aspiration or a testicular sperm aspiration. This can be done only in cases of obstructive azoospermia, but in non-obstructive cases, a testicular sperm extraction or a micro-TISA, that is micro dissection testicular sperm extraction, can be done. So for patients with non-obstructive azoospermia, microdissection, testicular sperm extraction is done, not aspiration. In obstructive, we can do, as I said, PISA or TISA. These are from the latest ASRM guidelines of 2020. Now, in men undergoing surgical sperm retrieval, either fresh or cryopreserved sperm may be used for ICSI. So I will come here in the next slides that fresh or even the cryopreserved sperm, they give the same results. So I think we will skip these procedures. So in men with azoospermia due to obstruction undergoing surgical sperm retrieval, so this is the same. So here multi-center trials have been done, but they say these are of low quality, and they say that fertilization, pregnancy, live birth rates was similar for epididymal and testicular derived sperm in men with azoospermia due to obstruction. So either of the procedure can be done, PISA or TISA. So here, so coming to microtessy, it is based on the premise that potential areas of spermatogenesis are present even in the smallest of testes. So every testis, they say, has got sperms, and even in cases of high FSH. So indications of microtessy are hypovolumic testes, even if it is less than 10 cc, small gonads, repeated negative outcomes in routine tessy, in Klinefelter syndrome, hypogonadotrophic hypogonadism, in undescended testes, if there has been a torsion testes, damaged testes. So in all the testes, you may find sperm, but the expertise has to be very high. So in a meta-analysis of published studies for men with non-obstructive azoospermia, microtessy was observed to result in successful extraction 1.5 times more often than non-microsurgical testis sperm extraction, and testis sperm extraction was 2 times more likely to succeed when compared to aspiration. So microtessy is a surgical procedure that involves wide opening of the tunica albuginea to allow examination of multiple regions of testicular tissue, each of which are oriented in a centrifugal pattern in parallel to the intratesticular blood supply, allowing extensive search of nearly all areas of the testes with limited risk of devascularization of the tissue. Conventional TISA has also been associated with decreased post-op testosterone levels, and many men with non-obstructive azoospermia have baseline testosterone deficiency. So this may be a side effect, but less effect on testosterone level is seen with microtessy than with conventional TISA. But testosterone deficiency requiring testosterone replacement remains a risk even after microtessy. So now, here sometimes with the embryologist we have a controversy, but various studies in the which have been published, and it has been said in the latest American guidelines of 2020 that in men undergoing surgical sperm retrieval, either fresh or cryopreserved sperms both give the same result with ICSI. So for men with the obstructive azoospermia, adequate sperms are typically present to allow sperm cryopreservation with high chances for survival for use in ART. There are no substantial differences in IVF success rates, so sperm retrieval and cryopreservation may be done prior to ART. In men with non-obstructive, some centers, they perform simultaneous sperm retrieval with ART because the number of sperms obtained may be limited and sperm may not survive the cryopreservation. So a recent meta-analysis evaluating the use of sperm from men with non-obstructive azoospermia, they observed no differences in fertilization, pregnancy, or live birth rates from ICSI in men for whom sperm was extracted and used with or without cryopreservation, as long as there were sperms of adequate number and they survived cryopreservation and thawing. Now we have already covered this. Now just a small word about after vasectomy. So couples desiring conception after vasectomy, surgical reconstruction may be done, sperm retrieval may be done. Both are viable options for these patients. but limited data exists comparing outcomes for strategies for men interested in fertility. So here retrieval will require use of ART and ICSI to achieve a pregnancy, and the couple's decision may be influenced by the maternal age and the cost factor, and also if there are other concurrent causes of infertility in the female. So there ART would be of more benefit. And also if the vasectomy has been long standing, like over 25 years, so there also reconstruction will not help much and ART has to be done. So just one slide about assisted reproductive techniques according to the sperm concentration. So here IUI, if it is less than 15 million but more than 10 million, IVF is done if it is between 10 to 5, and ICSI if it is less than 5 million. So indications I will not be covering. Antioxidants, in the latest ASRM guidelines, they don't have much evidence to support the use of antioxidants. So I hope I have done some justice to the topic. Thank you so much for patient hearing.
Thank you, Dr. Sonu. I request Dr. Surekha to conclude the session. Over to you, Dr. Surekha.
Questions I think we can take later on.
The end, yes. This was most elaborative, actually, the talk. Yes. Over to you, Dr. Surekha.
Yeah, namaskar, everybody. And thank you, Dr. Seema, for giving me this opportunity. And Dr. Sonu has really done a good job with this difficult topic. And I feel this topic of male infertility and the treatment part requires a multi-specialty approach. So we should not be, stuck with the patient. Whenever we think we cannot do it, we should refer the patient on time to the specialist. That's what I want to convey here.
Dr. Seema, we can have some views of Dr. Sunita also. So on this.
Yes, Dr. Sunita, yes, she can share her views. Sunita ma'am is there.
Oh yeah, I'm here. I'm very much here.
Yes, Dr. Sunita, please share your views on the topic and Dr. Sonu's talk. You have justified actually, Dr. Sonu.
I'll just share one of my patient of hypo before puberty. मैंने अभी उसका पिकअप और एम्ब्रियोस बना के रखे हैं. So this patient had hypo before puberty. He was only on SCG when I got his semen analysis done. Initial 2-3 reports were nil and then 2 to 3 million. So I just, because now he was married and he wanted to have a baby. So what I did, I just added this HMG twice a week for 2 months and I got 15 to 20 million count. And then I stimulated his wife and ICSI has been done and we have preserved, I think 11-12 embryos. Okay, so this जो इसने सोनू ने अभी पूरा डिटेल किया है hypo before puberty and after puberty, and adding up HMG is really a good idea. Again, now he's on SCG. I have stopped HMG. I don't need now. But she has actually given a very clear concept of this hypo before and after puberty and why to add LHFSS and why not only SCG works. So it's really wonderful. As far as antioxidants is concerned, I feel the most important antioxidant is astaxanthin. If any preparation which is containing only lycopene, vitamin E, this and that, and if it is not having astaxanthin, I don't think it is going to give any effect on whether it is count or motility. So, I mean, if we are giving any preparation, we have to look for it. One thing. Second thing, the CoQ, which they are giving in homeopathic doses, 50 milligram, it is not at all done. Minimum 200 or 300 milligram per day is needed to give a therapeutic dose. So these 2-3 takeaway points from my side.
And one more important, very important point, like Dr. Sunita was also saying, that if the patient is started on this therapy and they have 2-3 million count, they keep on waiting that, okay, it may become normal, but at least that those sperms should be cryopreserved so that if they do not increase, at least we can do IVF for these patients.
Because he came to me for pregnancy. Both of them, they came कि मैम मैं ये ट्रीटमेंट लगातार ले रहा हूँ and now I want to go for ICSI. So I saw it was 2 million, 3 million. इसके जितनी भी reports थी, I just added HMG for 2 months, 8 weeks, and count became 15 to 20 million. That is what I wanted. And
thank you, Dr. Sunita, for the most important inputs, and Dr. Sonu for the second session. We have wonderful chairpersons for second session. Dr. Rekha. Dr. Rekha is contesting for. Dr. Rekha she will speak once Dr. Sonu introduces her. Yes.
Thank you, Dr. Seema, for inviting me here.
So, Dr. Rekha is Medical Director, Miracle IVF Hospital and Chandan Hospital, Bangalore. And so there is like we can see, she has so many awards and facilitations and papers and publications to her credit. So, but the most important point here, I would like to highlight that she is the candidate for chairperson of FOCSI Clinical Research Committee. And I would like invite Dr. Rekha to just say a few words. And I request everyone to vote for her.
Thank you so much,
Yeah,
Dr.
Rekha.
Sonu. Yeah, thank you so much, Dr. Sonu. First of all, let me thank Dr. Seema Mittal for inviting me for such a wonderful program. Infertility is close to my heart, and she has selected one of the very practical and important points, that is IUI, because whether the new ART rules have come or the old ART rules are there, it happens that many of the gynecologists and regular obstetricians want to do IUI. Patients also want to get the IUI done so that they get a best result at the optimum cost. And also the facilities are so optimum in their centers for these patients, so that if the pregnancy happens with IUI itself, they don't have to shift the patient to the IVF center. So all ends there, and that is the best result for the patient. So we have Dr. Seema Mittal here to talk.
Dr. Rekha, just one, I would like to interrupt, sorry. Our other chairperson, our very dynamic secretary of IFS Punjab chapter, Dr. Sarabjit, he has also joined. And he was the treasurer before becoming the secretary. And he has organized quite a few annual conferences and has many papers and lectures to his credit. So we welcome you, Dr. Sarabjit. And I think now the chairpersons can invite Dr. Seema for the talk.
Welcome, Dr. Sarabjit, my co-chairperson. I would like to add one point here, that I am also the founder EC member of the Karnataka chapter of IFS. Now I'm going to introduce Dr. Seema Mittal, and I'm very happy to introduce her. She is MD Obstetrics Gynecology from Sevagram. She is also the director of Lalita Memorial Hospital Private Limited at Rewari. She has the credit of giving as the first IVF center in Haryana. She is also the past president of Rewari Obstetrics and Gynecology Society, chairperson of WDW IMA Rewari, that is the Women's Wing IMA of Rewari. She is the secretary doctors for the society, the treasurer of Haryana IFS, past treasurer of IMA Rewari. She has award from the president for book, that is Sukhada Matritva, that is on women's health, that is a maternal health. Local champion award also she has bagged from government of Haryana. She is an infertility specialist who has been practicing also the obstetrics and gynecology at Rewari. Over to Dr. Seema Mittal. Dr. Seema is going to speak to us on IUI in treating infertility all over the globe. Over to Dr. Seema.
Thank you, Dr. Rekha. Thank you, Dr. Sarabjit. It's indeed pleasure to have you all on this platform, and I'm sure we are going to have all the queries solved in the end. Welcome, Dr. Sarabjit.
Thank you.
Good evening, friends, once again. And why we have taken this topic, because when we talk of male infertility and IUI, there are so many may or may not be. And Dr. Sonu has fully justified the topic of medical management. But if not medical, then what? Then we have to go for IUI. So I have tried to touch all the troubled area in the field of IUI, and I have tried all my best efforts to simplify the procedure for all our attendees, and try to collect maximum evidence from the literature. And I hope it's worth the time that you are sharing with us all. So I think we're all slides. So, despite extensive literature, controversy remains about the effectiveness of IUI in relation to IVF and ICSI. So, despite extensive literature, controversy remains about the effectiveness of various procedures, especially in relation to IVF ICSI. like how Dr. Sonu talked about IVF in ICSI for obstructive azoospermia, non-obstructive azoospermia. And if you go to the history, IUI to inseminate a woman came into history around 1455. Not really published data, but that was the time when the Portugal princess was married to Henry IV, and she had insemination. That is what the historians say. So when we talk of IUI, one important thing that I want to tell everyone is that we have to, again, we have touched. So whenever we take up a patient for IUI, the patient selection is very, very important. We have to examine the patient, do upper speculum examination, do the semen analysis, and then we have to proceed. Next. IUI, there is a question whether it is beneficial or not. Definitely it is very much beneficial in people who are unable to or would find it very difficult to have vaginal intercourse because of clinically diagnosed physical disability or psychosexual problem, or people with conditions that require specific consultation in relation to the methods of conception. For example, HIV positive patients, or now with same-sex relationship, the IUI is definitely beneficial. Now there are certain indications of IUI because of male factors, certain female factors, and then other indications. So if there is anatomical defect of the penis, or there is ejaculatory dysfunction, or there is impotency or coital issues, and immunological is one of the most, it's not so common, but this is an important cause for reason for IUI. Then increased viscosity, this is the problem that we come across many times, and I would like all my chairpersons to share the inputs how they handle this problem of increased viscosity. Then oligoacinospermia and sperm cryopreservation prior to treatment of husband cancer. Then process semen of HIV positive husband to HIV negative woman. This is again a topic of debate. I will be talking some about it from the literature. In female, again, the cervical factors are important. Ovulatory dysfunction, again, a debatable topic. Then unexplained infertility and minimal endometriosis. These are two areas where we utilize the IUI for non-male indications. Anti-sperm antibodies in the cervix is another important arena where IUI really helps. Then psychological and psychogenic sexual dysfunctions are another issues. So next, we can skip this. Like Dr. Sonu said, the obstructive azoospermia, non-obstructive azoospermia, we can go for ICSI, but the truth remains that results of ICSI are till date not really commendable. And with our area patients who are so poor, who cannot afford, we still go for IUI when the couple doesn't wish to go for ICSI. And donor insemination has to be considered in conditions like where there is a risk of transmitting genetic disorder to the offspring, or there is a risk of transmitting infectious disease to the offspring or the woman, and severe IRH isoimmunization. That does make an indication at times for donor IUI in our setup. So there are certain contraindications to IUI. That is what I said in the beginning, that we have to examine the patient in first visit, be it IUI or IVF or any other procedure. Complete workup with all the examination and the investigation is a must. Nowadays, there is trend that we just don't put the speculum inside. We just go for ultrasound. And at times we'll end up into trouble. Either there is a small polyp, or there's a bad cervix, or there is atresia, or there is cervicitis. So they become contraindication to IUI. First, we have to treat the condition and then proceed. Then tubal obstruction is another very important factor that has to be ruled out before doing IUI. And then most cases of amenorrhea will not respond with IUI treatment, and severe oligospermia also may not go with IUI. So now I will be touching the areas where there are many controversies, and we go according to our experience and not the evidence, because literature will be all 50-50 for all the factors. And on this platform, we are going to discuss all these controversies later on. So for people with unexplained infertility or mild endometriosis, we may not do routinely intrauterine insemination till enough trial has been given for natural intercourse. So they have to try conception for 2 years. It can be up to 1 year, and then they go for either IVF or they go for IUI, and if it fails, then they will go for IVF. Course for stimulation. So in IUI, once we have decided that we are going for IUI, we have examined the patient, we have assessed, and now we have decided, then again the debate. Some will say that non-natural cycle is always best. Even for IVF, some recommend that natural cycle is good, some say stimulated. But as of now, I will say that stimulated cycle definitely gives better results in our practice, and same the literature says. Earlier, the major concern with NICE was that stimulated cycle will give multiple births. But the risk of multiple birth is more with embryo when they are more than 2 to 3, not with follicle. So risk of multiple birth with IUI for 2-3 follicle has to be much less than if 2-3 embryos were transferred. So, and no comparative studies exist to answer this question of relative risk. Shifting from unifollicular to bifollicular IUI cycle will potentially increase the chance of achieving an IUI pregnancy by 3.4-fold. Next. Stimulated cycles IUI comparing with IUI in a natural cycle, there was found to be significant increase in pregnancy rate per couple. Live birth rate for stimulated IUI compared to was recorded, giving an odd ratio in favor of superovulation and IUI. So all the literature, all the talks say that we have to do superovulation and IUI for good results. Now, when we are doing the stimulation protocols, our aim is that we should not have multiple follicles. We should not, our patient should not go into OHSS, and there should be good endometrium. These are 3 things when we are taking, and it should not be costly. So these are 3-4 factors that we take into consideration. And all said and done, clomiphene citrate still remains the drug of choice for all of us, maybe for all of us. Then letrozole, and then gonadotropins. Pregnancy rates can be even higher if most cycles were performed with 2 follicles using HMG, which also allows for a greater thickness in the endometrium compared to CC cycles. But what if we have more than 4? We take upper limit as 4. If there are more than 4 follicles, mature follicles, or more than 3 follicles, that's per literature, then chances of multiple births are there. So if we have put our patient on gonadotropin and there are multiple follicles, we try to convert this cycle to IVF cycle. If the IVF setup is not there, then you have to decide and you have to cancel that cycle and advise the patient that chances of OHSS and chances of multiple pregnancies are more. So letrozole becomes a drug of choice. With letrozole, we can combine HMG, and if the follicle, letrozole is not giving follicle, and we have to, our aim should be to get 2 or 3 follicles and good endometrium. And one more thing that I want to share is, whenever you're doing IUI, few things you should do on your own. One is that semen analysis. You should be very, very friendly with the sperms. Now you should know this is the normal morphology and this is the normal motility. And then you can really justify the patient. And secondly is your own ultrasound. When you monitor the patient, you see the follicle, you see the vascularity, you see the follicular blood flow, you know that this is a good follicle. Then you focus on the endometrium, you see triple layer endometrium with good vascularity and good cervical mucus, you know that this follicle is going to rupture. Because in IUI, all our results will depend on what type of follicle we have and when it is going to rupture, because post-rupture results are always better. So we should be able to appreciate that fluid in POD, if it has appeared, and if there is a mucus in cervical canal, they are all very good indicators of ovulation. So timing of insemination. Little evidence-based information exists to decipher what is critical for an optimal success rate. So it is rather surprising that few studies were designed to find the optimal time for insemination. In the majority of studies, IUI is done 32 to 36 hours following HCG administration. We all follow 36 hours HCG administration in our center. In one pilot study, it appeared that optimal time post HCG was 30 hours. So how do you plan timing of insemination? Timing of insemination will depend on the most of the literature, and we also do single transfer. We are doing single insemination. So if we are doing a fixed protocol, we are doing single insemination. It has to be done after 36 to 38 hours post HCG, definitely. Double insemination, will be done 24 hours and 24 hours. So in 48 hours, we are doing 2 inseminations. Or there may be variable protocol when we are doing TVS and we see post HCG, patient is ovulated, we do single IUI. This is what we were following earlier. And if she has not ovulated, IUI once after 24 hours was done. Exact timing of IUI makes all the difference to success of your patient. Postponing IUI until observation of follicular rupture may yield a higher pregnancy rate. Double versus single IUI, no difference in pregnancy rate between single versus double. An exception suggested is if total motile sperm is less than 1 million on insemination day. Dr. Sonu will not agree with me. A second IUI can be offered within next 24 hours. This is, we are talking about the patients who may not afford IVF, who are not willing, because like when we talk of cycles, we say 3 cycles or maximum 4 to 6 cycles. But in our patients, for 37-year-old patient, I did almost for 1 year, I was doing her donor IUI because she was very, very poor. She would earn and then get some money for IUI, and ultimately she conceived and she had a daughter. So individual variations will be there according to the place you are working and your patients. But this is what the literature says. So no difference in pregnancy rate between single and double. Next. Single IUI time post-ovulation gives a better clinical pregnancy rate when compared with single pre-ovulation. So post-ovulation, when we can do post-ovulation, it will definitely give us better result than single pre-ovulation for non-male infertility. Whereas for male factors, pre-ovulation double IUI gives a better pregnancy rate. And here again, we at times admit the patient when we feel that ovulation is going to happen, and we can keep the patient. We do in the morning also scan and evening, and by evening, if it has ruptured, we like to do IUI at the same time in the same sitting. Semen quality and prediction of IUI success. Double insemination, Dr. Sonu talked about split ejaculation. She talked about collecting the sample in the second sitting. So double insemination significantly improves the chances of pregnancy in male factor sub fertility. Earlier, we were taught that 16 millimeter follicle size, once it is attained, you can give HCG. But data suggests that pregnancy-related diameter of the leading follicle in CC cycle is significantly larger than that in gonadotropin cycles. So the best time for HCG trigger in the CC cycle is when the leading follicle reaches 20 millimeter, whereas in HMG cycle, 18 millimeter appears optimal. So unexplained subfertility is the area where we go for IUI when everything else fails and patient is not willing to go for IVF. So before IVF, how should we proceed? We can see in the next slide. So it is unexplained subfertility. Then age of the patient is the single most criteria that gives us time to plan the treatment. If she's more than 39 years age, then irrespective of duration of infertility, we go for stimulated IUI cycle, maybe 2 cycles maximum, and IVF. If she's between 35 to 39 years, we all know that ovarian reserve will become poorer and poorer day by day. We have to really work fast. So if she's married for more than 1 year, then we stimulate again 2 to 3 cycles and we proceed for IVF. So for more than 35, the treatment remains same. If she is less than 35 years and if she's married for less than 2 years, here comes the expectant management. If it fails, then we go for IUI with FSH stimulation, 3 to 6 cycles, maybe maximum 6 we can go, and then we proceed for IVF. And if it is more than 2 years duration, we don't wait, we straight away either go for IUI or we proceed with IVF. IUI seems to be poor treatment option for women over 40 years of age. IUI in male factor. See, we need at least 5 million motile sperms per ejaculate for IUI to be successful. Less than this, definitely we have to go for IVF. Otherwise, 10 million is taken as the baseline. And the use of consecutive ejaculate is a new concept in overcoming male factor problem in IUI. I'm sure any of the chairpersons in the end would share their experience with this. We have framed certain questions also. So we will know from their expertise also. Next. So obtaining a second semen sample when the motile sperm yield of the first specimen is 1 million to 5 million significantly increases the total motile sperm count in the final inseminate. Split ejaculate is something that improves results in IUI, especially in asthenospermia, and failed liquefaction of semen sample. Here also it helps to some extent. So the results will vary with the sperm count. If it is total motile sperm count is 10 to 20 million, we take 10 million as the upper limit. We don't really promote IUI with the semen count less than 10, but 10 to 20 million, 18% conception rate per cycle, 5 to 10 million, 5.63%, less than 5 million also 2.7%. So if less than 5 million, okay, next. This is another debatable area. So these are certain trouble areas. What is the ideal sperm count? What is the unexplained infertility? What to do in endometriosis? Should we go for IUI in all endometriosis patients? So the literature says yes. If infertile women with grade 1 or 2 endometriosis, clinician may perform intrauterine insemination with controlled ovarian stimulation instead of expectant management, as it increases live birth rates. So in infertile women, if clinician may consider performing IUI within 6 months after surgical treatment. Here we differ because once we have operated upon the patient and we find endometriosis, we like to really work on same sitting. So we don't wait for 6 months, and if the house differs, we will like to take up this question that any surgical treatment, any management for endometriosis patient, if you have done, just take up your tubes are patent and it's mild endometriosis, you have to go for COH and do her IUI. If it fails, then you better take her up for IVF. Delaying treatment in endometriosis may just reduce the chances of success for that patient, and we may not justify in doing our job. So pregnancy rates are similar to those achieved in unexplained infertility. Next. As I have talked, that tubal patency has to be checked, and if there is a tubal block, we cannot go for IUI. And sometimes the patient is young, there is no risk factor, everything is fine. We don't really do tubal patency, but recommended is that it should be done before doing IUI. When we are ruling out everything, then we have to check the patency also. If there is a distal block, or if we find more important than the tubal patency is the tube-ovarian relationship. Normally the HSGs are done by a radiologist and then they say the tubes are patent, but I have come across so many times when the tubes seem patent, but when I see there is no spill in the pelvic area, and we do a diagnostic lapro and tubes are just edematous, and many times they turn out to be tubercular also. So HSG also, if you're doing that histosalpingography you're doing for your patients, which is better that you do at your center, or you read that X-ray very, very carefully, because for a gynecologist, it's altogether different how you interpret the X-ray. So if there is, you feel that tube-ovarian anatomy or the relation is altered, we go for diagnostic lapro, and if it is not comfortable, we go for IVF. Next. So these are certain male sexual dysfunction where IUI helps. Next. Similarly for female also we have vaginismus and superficial dyspareunia. These are other areas where it is a debatable thing. Next. This is important, which I want to discuss next. Yes. So serodiscordant couple, the man is compliant with highly active antiretroviral therapy. Man has had a plasma viral load less than 50 copies per ml for 6 months, more than 6 months, and there are no other infections present, and unprotected intercourse is limited to the time of ovulation. Here it is very important because nowadays we do come across patients where the husband is HIV positive. Either they request a donor sample, which I happily do, or they request from the husband sample only. Though the guidelines say that we can do HIV, but if I would like to read these lines carefully, that advise couples that the risk of HIV transmission to the female partner is negligible through unprotected sexual intercourse, advise couples that sperm washing may not further reduce the risk of infection and may reduce the likelihood of pregnancy. If couples still perceive an unacceptable risk of HIV transmission, after discussion with their HIV specialist, consider sperm washing. But when we are washing the sperms for HIV couple, we have to inform them that there is insufficient evidence to recommend that HIV negative women use exposure prophylaxis. Next. So what are the sperm wash techniques in IUI? These are two methods which are most commonly used, and this can be done by any clinician in their setup. One is the swim up method and other is density gradient method. When you're collecting the semen, you have to sperms are obtained by masturbation in a sterile container. Abstinence for 3 to 5 days is must. No lubricant should be used when patient is giving the sample, and container should be warm, and addition of culture media can help. So I will just briefly tell you what is the swim up and what is density gradient. We can have the previous slide. Yes, swim up is when we are just taking equal amount of media, that is gamete buffer, and we are taking the semen sample and we centrifuge it, and then the pellet is formed and we discard the supernatant, and the pellet again we take the upper end, we again add the media, which stands for 45 minutes, and upper and middle part of the media is taken, of this supernatant is taken, and we again centrifuge for 1 minute. So the pellet which is formed in the end, and the sample is taken, again added 0.5 ml. Swim up, basically the sperms have to swim up in the media. How they will swim? Because they are heavy. When we are centrifuging them, they stick to the bottom, and then we again add the fresh media, and those motile sperm which swim in the upper layer are taken up for insemination. Whereas density gradient is just the reverse of swim up, that is swim down. And density gradient is better because it removes all the debris, all the infected material, and the abnormal sperms as well. So here again, two media of different gradient are taken and then topped up with the semen sample, and again the pellet is taken and it is washed up. Rest of the technique is same as for swim up. So these two methods are followed basically, and out of these definitely the density gradient gives better results in IVF and IUI cycles, especially when the count is low. Next. Hepatitis B and hepatitis C, no sperm washing is done for them. What is the interval? This is again important because some of the centers, they get semen sample washed by the pathologist, which comes from the lab, and it may take longer. So there can be exhaustion of energy sources in the sperm washing medium by the motile sperm metazoa. So IUI should be done as fast as possible after sperm washing, and this is possible when you are doing it at your center only and you are monitoring the patient at your center. Next. How many cycles is again a question that I said earlier that we have done for 1 year also continuously. So pregnancies resulting from IUI occur during the first 3 to 6 treatment cycles. Most women conceive after 4 to 6 cycles of IUI, and fecundability declines by half to 2/3 thereafter. Endometrial stretching is useful in increasing pregnancy rates after failed previous intrauterine insemination trials when it is performed in the mid-proliferative phase. This is just a diagram of IUI technique. So you have to go see what you have to assure that before doing IUI, you have examined the patient, you have seen the uterocervical length, and you have seen the external and internal os. It is negotiable if it is a cervical stenosis or atresia. You have to manage it first, because there is once the blood on your catheter, it will spoil all your results. So any blood, any secretion, if it goes into the uterine cavity, or any air bubble, if it goes into the uterine cavity with your catheter, the results will be very, very poor. So you have to go just beyond the internal loss, and once you, it's better that you do it under ultrasound guidance. That is what we do. We do it under ultrasound guidance, and you just go beyond the internal loss, maybe 1 centimeter, or you can go more also. But if we go further, then chances of uterine cramps, pain are more. So we just go beyond the internal loss, and once we have in the internal loss, we just slowly infuse the sample into the uterine cavity. And another aspect, next. Any effect on the mobility? Some say that you take rest, some say that rest is not needed. So no difference was found in miscarriage rate, multiple gestation, live birth rate between the groups who took rest and who did not take rest immediately after IUI. 10 minutes is the time that we give to our patients after IUI. Next. Luteal phase support in IUI cycle, it has to be like how we give support. It is definitely, it improves the results. Though again, it is a debatable topic, but when we are doing, especially when we are stimulating with gonadotropin, we give uterine support to all the luteal phase support to all our patients. And that is what the literature also says. Based on the study results available in the literature, it appears to be beneficial to supplement the luteal phase in gonadotropin stimulated IUI cycles that yield more than one follicle. And in the end, when we talk of IUI, IVF and treat our infertility patient, my take is that we must accept finite disappointment but never lose infinite hope. And let us hope that after this webinar, we are justified and we get important inputs. Thank you for your patient listening. Thank you so much. And over to you, Dr. Sonu.
Thank you so much, Dr. Seema. I would like some comments from our chairpersons, Dr. Sarabjit.
Dr. Seema, that was wonderful. It was detailed, you covered almost every part of an IUI. For an unexplained infertility, Dr. Seema, when we talk about the unexplained infertility, especially in the part of the world that we are working with, we have got still marriages done at a very early age. Okay. So according to the guidelines, when you go by the UK guidelines, the NICE guidelines, after 2 years of an unexplained infertility, they suggest you to go for an IVF. Okay. So, after 2 years of an unexplained infertility in Indian scenario, at the age of 25, 27 years, it is very difficult, for the patient to convince to go for an IVF. Just after, when you say, especially your tube is open, your semen is absolutely fine, you are regularly ovulating. So I suppose IUI definitely is a better answer. And lately also in the newer, evidence, there is recommendation that IUI should be actually considered in unexplained infertility and in the milder part of the endometriosis and male subfertility, which actually is a category of unexplained only. So how do you see this? In unexplained infertility, you would like to go for an IVF, or you would like to give it a try for 3 to 6 months? That second point is again practical, and that is hardly you would find any patient actually sticking to you for 3 IUIs.
See, unexplained means if everything is fine. I like to take my patient up for diagnostic laparohysteroscopy, and I do catch on something, it doesn't remain unexplained anymore. And most of the patients, I think 7 out of 10 conceive after simply a diagnostic laparo and just touching the ovaries once, and not really IVF. Once patient crosses 30 in India, almost 10 years, 20 years, people don't go for IVF, or they want guarantee from, if all the patients coming to our center, they want guarantee. You can take up any treatment, but you have to assure that you will give them a baby, which is very, very difficult. So we rule out everything, and I still feel that there is nothing called unexplained. There is some reason. Only thing is that we fail to get it. Nowadays, with all the modalities of investigation, either the endometrium is poor, or the follicles are not good, or there is something, or there is mild endometriosis, something or the other we do come across.
So you're doing diagnostic laparoscopies in these unexplained infertility patients?
If male factor is normal and everything is unexplained, yes, definitely I would like to go for laparoscopy and find a reason which cannot be seen on ultrasound or my clinical expertise. And even the little fluid in POD, and at times, we send it, and then the pathologist tells me that there are macrophages and it appears like she can be early tubercular. And then again, some people will disagree that it should not be done, but giving them simple ATT, they conceive. But when we go to big conferences, they say that you will create sanatoriums because you are giving ATT unempirically. So,
No,
like
these
some
kind of patients, Dr. Seema, maybe we can just tell them to be at home, and if they are young age group and unexplained infertility. So if they have been coming regularly, I sometimes tell them, okay, for 3 to 6 months, you take a break, you be at home, try naturally. And sometimes the patients come back with conception. I don't know.
Very small population. That kind of a thing is a very small population. They would have tried enough, and as a last
Exactly.
resort, they would have turned to us. So once they
No, but
step into
at
the
an age of 25 or like 27 also, still, if they have been coming regularly and we've done 3-4 cycles of IUI, maybe instead of jumping to another, maybe we can give them a break or something.
even if you don't give a break after 3 IUs, they are going to 100% disappear, at least to the next clinic, or sit at home for next 3 to 6 months, and then only they'll come for IVF. Even if you push them to IVF, they will have not pushed, but I mean to say, even if you have advised IVF, even in a very genuine case, they would not accept. They'll say that my age is young, let me try on my own, and so they'll find some reason not to go into IVF.
And
So
and
whether
and
you
and it is so difficult actually, after 3-4 years of marriage life, if you tell them to have a natural intercourse, half of the time they'll end up fighting over the bed rather than doing anything practical. So these all practical things, we should keep in mind. The reason why I say to this is because the Dr. Seema Mittal ma'am rightly pointed out that it should be individualized rather than focusing on one particular guideline that comes from the West, where and they start seeing the patient only after the age of 35, 37 years, compared to what we are doing over here. After getting marriage, and after 1 or 2 years they'll come to us and say, look, treat us. So we should actually follow those guidelines with our
Yeah,
inputs.
exactly. What Dr. KD said, that we should come with our own guidelines rather than following the West, because our population is much different from the Western population.
there are two things here. One is mentality of our people is different, unlike the Western, where our people in general, most of them would want to have a pregnancy somewhere around 30, unlike Western, where they don't even think till 35, probably. That's one thing. And the second thing is the fertility itself is at, say, 6 years more advanced in our population compared to Western. So if a woman of 36 has fertility potential Western, we should equalize it to 30 age. That is a chronological age in our population, isn't it?
Yes, I agree.
So we have, I think, small presentation from Team Jagsonpal. Then we have certain questions, and we will need valuable inputs from all our chairpersons. And I think Dr. Dipankar Banerjee sir will also join us for the same.
Jagsonpal Pharmaceuticals Ltd proudly presents PRORETRO micronized dydrogesterone tablet 10 mg. Jagsonpal Pharmaceuticals is manufacturing all the active pharmaceutical ingredients and intermediates concerning dydrogesterone, making India self-reliant. Atmanirbhar Bharat. Vocal for local. Go for PRORETRO.
Mr. Rohit from our sales team.
Right, Deepika ji, thank you.
Good evening, all the esteemed faculty and the attending doctors. Myself, my name is Rohit Kumar, based at Panipat headquarters from Naari division of Jagsonpal Pharmaceuticals. Today, seek your support for our newest brand in our product portfolio is your PRORETRO 10 mg milligram tablet of the micronized dydrogesterone for the luteal phase support in the ERT, recurrent pregnancy loss, and the threatened abortion. Doctors, we take immense pride to share that the years of the R&D of our Jagsonpal Pharmaceutical Limited is successfully manufactured our micronized dydrogesterone. The quality of our brand PRORETRO is backed by the bioequivalence study, also providing the clinical safety and the efficacy of our brand PRORETRO. With these clinical advantages, PRORETRO is assisting the motherhood, delivering happiness at a remarkable reduction in the cost of the patient. We're providing just 50 rupees per tablet cost to your patients. PRORETRO is really readily available at the counters near you to you prescribe. Our sales team visiting regularly you to striving to make your bulk purchase experience with effortless and worthwhile. We thank you for this opportunity to connect with you all and look forward of your support for our brand PRORETRO. Doctors, other excellent products are the Cystelia M, the molecule Mainstol, D-inositol, L-methylfolate, vitamin D3 with the ideal 40:1, which enhance the fertility. And also we have the Endoreg and 2 mg tablet of the Dydrogest for the medical management of the endometriosis and endometriosis associated pelvic pain. We look forward to your support for these brands. Thank you once again for all the faculty members and all the attending doctors. And join us tomorrow for another webinar. It's based on Pensumosia on GTD organized by ISPAV. The webinar ID is there. Thank you very much. And thank you, Dr. Deepika, to give me the opportunity for this wonderful session. Thank you.
Thank you, Rohitji. I'm so sorry. And there is question from Dr. Nitin. He is asking about the ART registration for level 1 clinic and IUI insemination. Anybody who is doing IUI needs to get registered. And for rest of the details, you can go to ICMR website and download the form, fill it, and apply accordingly. So can we have the first question, Deepika ji? So Dr. Sonu has talked at length about drug treatment, but she's not really in for many drugs for infertility, male infertility. So I will put this question to Dr. Sarabjit. Dr. Sarabjit, you will share your personal experience and tell us also what more you know about drug treatment in male infertility.
The only evidence-based treatment that is there in male infertility is obviously the hypogonadism, where we can, go for the treatment. Otherwise, if it's a hypo, there's no treatment. Even for an unexplained, there is no treatment. Yes, empirically, you can give, the sperm energizers, but there's no evidence that they are going to give any better, semen parameters. The evidence says so. At least in my clinical practice, in those cases of severe OAT, where, obesity is there, so I have found there's anastrozole, the letrozole, combination better and improves the, sperm parameters, but they improve the sperm parameters not to the level of an IU and even to a natural. They would give you some amount of a better semen parameters, but it will never be for my side. It never actually was to the level of that I would let them go and try naturally. So these two basically treatments that I give to my patients. Yes, empirically, I would give, sperm energizers to those patients who are very young, at least to, give them a psychological comfort that something is there. But there's no evidence that these treatments, they work. The only treatment that works is in hypo, and probably in obese male, which is severe OAT, these anastrozole and letrozole.
Dr. Sonu, you talked about testosterone. How do you give, where do you give, to which patients?
No, testosterone is not I just found a paper that where the urologist, there was a survey where urologists have been giving testosterone to quite a few patients with male infertility. It is doing more harm than it is doing any benefit.
That is what, right.
And I have no personal experience of giving testosterone to any patients. Maybe other chairpersons
we have small evidence where the stop treatment, start and stop treatment of I have not given testosterone to any of my patients, neither I recommend anybody, but yes, there are small evidences where they say that giving and stop treatment of testosterone just to give it a push actually works in some patients. I have not tried. There are only small evidences. Otherwise, testosterone should not be used in these patients unless patient doesn't want to conceive, and only the sexual desire like problems are there where testosterone might be of a help. Otherwise, for fertility, testosterone has no role to play.
So there are two papers there, infertility and sterility, and they have done a survey of quite a few centers in the US, and one has been it was published in 2010 and now again in 2020. And urologists, they have been giving testosterone for infertility also. But in this survey, they have found it is doing more harm than it is doing any benefit to these patients.
Dr. Rekha, you would like to add anything? And do we have Dipankar sir here? Deepika ji, you can take him in.
No, definitely testosterone is a strict no.
Sir, join kar rahe ho?
Hello.
Yeah, Dr. Rekha?
Yeah. Testosterone is strictly a no. Our HMG and HCG, as Dr. Sonu explained in her presentation, it's cases of hypo. That is number 2. Number 3, drug-wise treatment is treat the semen infection, if at all you find any. And number 4 is role of antioxidants is still a big question mark because certain people do really believe in antioxidants, and especially in cases where the DFI is more than 30 and where there is a recurrent implantation failure or abnormal sperm morphology, etc. But still, that's a big debate, the use of antioxidants.
So these are all off-label drugs. Only gonadotropins are approved by FDA.
Yes.
And all other these CC and aromatase inhibitors, antioxidants, these are all off-label drugs.
Yes.
So next, antioxidants and motility enhancing drugs. There's such a huge market and there are so many good sponsors. At least we have to say yes to our antioxidants. Dr. Sarjeet, we start with you.
No, ma'am, we don't have any evidence has already been discussed. I give it to those patients only who are, the young patient, at least to give them a mental comfort, because they are only the vitamins. Okay, so probably, I don't know, it is not going to work obviously on the fertility part, but at least for the mental, this thing. Psychological. Otherwise,
even for motility enhancing, I think pentoxifylline has been used, but it is also still an off-label drug.
Yeah. Probably we may give antioxidants, but meanwhile we should also tell them that the other vices like your smoking, alcohol, scrotal temperature, lifestyle, those things have probably to be more emphasized than you rely on drugs and everything will be well like.
So talking about evidence, even there are multi-centric trials that all these lifestyle measures also, they have just a small bit of benefit to these patients. Usually they have to go in for ART procedures only.
Yeah, along with the ART procedure.
See, all the supplements, vitamin C, vitamin E, everything they have claimed that it improves all the results. Dipankar sir, have you joined, sir?
Yes.
So, sir, you answered our first question also. Deepika, can we go back to first question? Yes, drug treatment in male infertility, sir, your experience, what do you give to your patient? Do you give first of all, then what do you give? And how long you give? And what do you get in the end?
Drug treatment in male infertility should be decided first whether this infertility is how severe and whether this is treatable or not. That I do first. That is my andrological evaluation first. If it is treatable, then we should treat it. Otherwise, whatever it is available with the patient, we should use it either through IUI, or if it is not possible with the IUI, we do IVF or plus ICSI. Second thing, if it's treatable with the drug, then whatever just panelist has said, it's the same thing. It is available in world like coenzyme Q10 and vitamin E and vitamin whatever it is. But very rarely, if it is while doing the andrological evaluation, if it is hypogonadotropic hypogonadism sort of thing, then we try with HCG for 2-3 months, 2000 international unit twice a week for at least 3 months. Then we do it again, and if it is something, then continue or add FSH also.
Not for 2 years, how literature, like when I was reading case presentation within 2 years and patient conceived and
it is not possible for 2 years because you can say it is 2 years, but for
India it is not possible, sir.
It's not possible.
Right, sir.
The thing is, what I am doing, I am not waiting too much because patient is already had an infertility course for at least 5-6 years if they are coming to my clinic and they want a result, they want a baby, and whatever it is available with their semen, with their sperms, either we should go ahead with the IUI, or what I am not pro IUI, I am pro IVF, and I do IVF ICSI with those patients.
Right, sir. So next question also we discuss. So next, antioxidants and motility enhancing drugs. Do you recommend it, sir, or are you using it at your center?
Definitely, we always, I think every practitioner has given whatever you just said about this coenzyme Q10, that is slightly evidence-based, and other vitamins.
So you are convinced with CoQ10, sir? Coenzyme? Because none of the chairpersons are convinced, and it is so costly also. And in the end, if you tell your patient that you spend so much and it is not effective, then I mean we are not ready for that.
See, one thing is very clear, that sperm motility is by mitochondria at this neck of the sperm. So mitochondria's last respiratory chain enzyme is coenzyme Q10. So if we can give that enzyme, that becomes an amrit for all cells. So it is better to give that medicine rather than not giving anything. So although it is very expensive, but definitely we give it.
Right, sir. Because Dr. Sarabjit was all against it, and so was Dr. Sonu. So I just wanted somebody in my support, so I gave you a call. So next question. Dr. Sunita Chandra is not with us. Dr. Sonu. Next question.
There. Yes,
She's there, so she's not participating. Dr. Sunita.
Unmute yourself, Dr. Sunita.
For antioxidant, I said CoQ 300 is the only thing, and another is astaxanthin. बाकी आप lycopene दीजिए, vitamin D दीजिए, whatever you want you give. But these two things really have a role, and they do have some place. So if you want to give, then give, and not in homeopathic dose. Again, I said CoQ has to be 300 pura and astaxanthin in full doses.
Thank you, Dr. Sunita. Yes.
I agree.
Things you are taking care of, and then you have to look for. I mean, if the motility is less, count is less, look for other things also, like thyroid, TSH, prolactin, which we are not looking in male patients. So male partner में ये भी देखना है, and blood sugar, which is again very, very important nowadays, that every second person is diabetic, whether it is young. And then obviously they will not come out that they are alcoholic. I mean, they will not say they are alcoholic. They'll say कि हाँ किसी दिन लेते हैं, और जब वो किसी दिन आप पूछेंगे तो पता चलेगा वीक में 5 दिन लेते हैं.
And husband and wife fight.
Smoking. They will not come out with that they are smoking. They'll take hookah. So that's again the same thing. So you actually nowadays, even I'm surprised to see all these youngsters coming with all these history of all these things, but you have to get these kind of history when you ask again and again. I mean, the questions which you have to ask them, they will not say. वाइफ भी नहीं बताएगी, बहुत धीरे से बोलेगी कि हाँ डॉक्टर साहब कभी-कभी ले लेते हैं. और जब आप डिटेल हिस्ट्री लेते हैं, आप उनसे पूछते हैं, सी इट इज वेरी वेरी इंपॉर्टेंट, व्हाई आर यू हैविंग दिस काइंड ऑफ थिंग्स, तब बताते हैं कि हाँ डॉक्टर साहब ठीक है, मैं ले लेता हूँ पार्टी. मैं लेता हूँ पार्टी. कितनी बार होती है पता चला, महीने में 10 दिन पार्टी ही होती है.
There's a very important thing, people who are doing gymming and taking supplements also,
yes,
there compounded oxidative.
yes, very important. So they keep on taking steroid. क्यों ले रहे हैं? क्योंकि साहब बॉडी बनानी है, मसल्स बिल्ड अप करनी है. किसने दिया था? जिम वाले ने दिया था. And then you see कि वो क्या ले रहा है. And that is the thing that they are having low count or low motility. अभी कुछ testosterone पे बात हो रही थी. I am very much against testosterone because this is not going to do any benefit. Rather, it gives you, it doesn't give any response. I mean, it's harmful. So in case hormones has to be given, then it has to be HCG or HMG. Testosterone, yes, in patients where it is required, like I said, where there is a delay of puberty, where there is, no secondary sexual characteristics development, then you go for it, and then you see chromosomal and everything, and then you prescribe testosterone with consultation of endocrinologist.
Agreed,
Dr.
Dr.
Sunita.
I make sure I take history of all my male patients, even if the normal count is there. I ask them, are you taking alcohol? Then I tell them your sperms are actually weak, you have to leave it. So that's my history. Dr. Rekha, you were saying something?
Yeah, Dr. Seema, wife says husband takes alcohol 5 times a week, and husband says I take once in 5 weeks.
सही बात है, एकदम सही बात है.
So next question. Rule of next. Okay, now this is one problem: persistent unruptured follicle. What do you do when you come across? Do you come across such a problem, Dr. Sarabjit? If yes, then what do you do?
Yes, ma'am, a lot. Actually, in my practice, if you see, I would call 30%. The literature says that it is close to 5 to 10%, but for my practice, it is actually the 30%. So most of these patients, if I come across, obviously I don't do the cycle, but then again, that's a debatable. And the next cycle, what I do is I try to change my HCG dose. If 5,000 that I regularly use, I go by 10,000. And sometimes I go by the dual trigger and, increase my luteal phase support. And sometimes, I even give an antag. I don't have any evidence to support this, this job. But then what I do is, before I giving the rupture, I just give an antag. The idea is actually to suppress the LH and then give it, so that, I feel that your proper LS surge would be there, and that would lead to the rupture.
Right.
So three things that I do.
Some sort of, this is endometriosis mild or something may be responsible if it is persistently high. So
Yes,
Dipankar
exactly.
sir can add.
No, it is okay.
No, reply is okay. Yes, Dr. Sarabjit is perfect. Actually, we've got another mentor now. Thank you, Dr. Sonu.
Yeah, Dr.
So,
Seema, one point I would like to add here. In these cases, when it is unruptured, the day 2 scan of the next cycle, you have to be very careful. See to it that the remaining or the progestational activity has not continued, like the formation of cyst and the follicles have really been down regulated. Then only you have to start the cycle.
Yeah, so we have to rule out certain, maybe there is some other associated problem, maybe there are adhesions, there is some endometriosis. If it is not there, then like Dr. Sarabjit said, we have to change the protocol and then see. Then next question.
Prolactin level also has to be checked in patients where
precisely
are getting continuous unruptured follicle. And second, very rightly said, before starting another protocol in the next cycle, if the follicle is still persisting, then I think it is better to give OCPs for one cycle, and then you can see. But prolactin level, even it is mild, it is just borderline, can give you unruptured follicle.
I feel prolactin in both males and females is a part of routine investigation in all patients.
It's done routine.
Dr. Sonu, you are getting, I think Dr. Sarabjit is doing your embryology part, but at times the sample doesn't liquefy. It becomes a nuisance when we are doing IUI. How many times you come across this problem, and what do you suggest for this?
I think Dr. Sarabjit can take this again.
Okay, another
Poor liquidation basically is related to your anti-sperm antibodies, again debatable, then your infections, again debatable. So when you're coming across liquidation and you want to go for a procedure like an IUI, we have ready-made a few medias available with the papain-based, captain-based medias which can be used. Otherwise, if they are not available, then simply what you can do is you can repeatedly, you can suck it and pull it down with your
that mechanical thing that really helps. You tweak it in a small, through a small needle, you aspirate, then you push it back, take it, and
that is the best way actually to this thing. If you want to rule out why this liquidation is happening, you can go for the culture media, but then again, that is not recommended.
We do culture for all our IVF patients, semen culture. Are you all doing semen culture?
We've stopped doing it because there's no role of doing culture nowadays. Okay, so we have stopped doing it for the past 2 or 3. We were used to do it and give antibiotic accordingly, but the recent evidence says that there's no need to do culture.
If you're going for ICSI, otherwise.
Yes, we don't do that because the leukocytospermia, it is very difficult actually to see it, and the way I beg my pardon to all my embryologists, the way we do the semen analysis is difficult actually to predict the leukocytospermia. For that, you will have to stain the slide and then see actually whether actual leukocytospermia is there or it's a pseudo state. So we are not doing it. So there's no role of doing any semen culture sensitivity test in the current male fertility treatment.
Yeah, we have also stopped doing it for the last 3-4 years. We used to do for all our patients, but now we are not doing.
I don't do. Regarding the mechanical liquidation, I just had to add a point to exactly what Dr. Sarabjit Singh had told is right. Just had to add a point that especially for the junior ones who have started, they should not entrap the air bubble in the syringe, because that will damage the sperm because of increased production of ROS, I feel.
Sir, Dipankar sir.
That's an important, actually, Dr. Rekha has mentioned a very important, but actually
Yes, very
the
important
liquidation
point.
needs time. And we as a clinician and our brothers, embryologists, they too do not have time. So after 5 minutes of, the semen would be lying and they will be hurrying up, yeah, liquefy. Then they will start doing this, and will write the report that liquefaction was not. Actually, they have not waited for the proper 30 minutes to one, that is the problem actually with this.
Actually, it
That's
should be done
affecting.
very slowly, taking the air and not taking the air, sorry, and slowly releasing roughly some 5 times. If they do that, if they do it very properly, that should suffice, and that gives a good liquefied semen.
But how many times do everybody experience this problem? I think it's not very common.
It's not very common.
But Dr. Seema was telling some 20% or something,
No,
or somebody was telling, as I
No,
remember.
not 20%, you know. Maybe once in a year you get a patient.
Yeah,
but
it's
then-
very rare according to
Very
me,
rare,
but
very
somebody
rare.
said,
But
yeah.
when you're
It's quite rare.
Most
Not
of
very
the time, we have not waited actually for the liquefaction time to, within 5 minutes, they
It's not
expect
given
some samples.
appropriate time also. Yes. The next question. Are there any questions? I think next. Yes. Yes, you have to share honestly your experience. How many patients you have inseminated when the husband is positive and you have inseminated after proper precautions and wife is negative. Everybody has to share. Dr. Sarabjit, your
Ma'am, the Cochrane report where they have reported close to 3,000 to 4,000, discordant couples where the husband is HIV positive with the, the CD4 counts below the level of 50. So categorically, they have mentioned that none of their actually patients who conceived actually with an IUI got HIV through their this thing.
they got
IUI.
HIV.
There was none of the patient actually got this HIV.
Okay.
Because we are doing the gradient media, so HIV actually rests on the most of the time in the leukocyte. It's not lying in the sperm, and most of the times it is density gradients, and we're doing a lot of other this thing. So there's no question of HIV getting transmitted through an IUI. But the problem practical over here is that you cannot tell to your patient that 100% this is going to be, because medico-legally you try to be very safe. Even if you have an evidence that there is no going to be, the HIV is not going to get transmitted through your IUI, but somewhere down the lane, medico-legally, you do not tell to your patient that 100%, and therefore the donor program comes into the play. I won't recommend the donor program. IUI is safe in HIV provided your CD4 counts are low, but donor is practical option. You understand, because of the medical part.
We cannot be 100% sure, because I have gone through literature and it says that you cannot be, you have to tell the patient there might be the possibility, and that says everything, because who would like to take the chance? So we don't recommend that you go with your husband's thing. You already has done something shit, and then again you're going with that IUI also, so better stay away from him. So
only point, even if you're trying naturally, there are 0.003%. That means after 1,000, intercourses, out of those 1,000, 3 chances would be there for HIV to get transmitted. So even if you're doing it naturally, HIV is not going to transmit. But then that absolute 100% that the Indian people expect, you cannot give the guarantee, and therefore it is all your counseling what matters.
Very right. And for RH negative, how have you ever done donor IUI for RH negative patients?
No, nothing. We have 100% close to 100% treatment in the form of NTD. So why should we?
And nowadays it is very rare that ICTs they have high titer or anything. So
yeah, and on top of that,
I did
even
for a
if,
patient actually. Yes, Dr. Rekha.
sorry, on top of that, even after ICT, everything, even if the baby gets affected, you have intrauterine transfusion and everything has gone so much advanced.
Exactly.
First of all, entity itself has become so rare now. So putting all practical scenario together, probably it's not a entity that is staying practically. Now, regarding this HIV, I had two things to tell. One is that you have to tell them there are very small chance also the possibility of wife contracting in spite of IUI, in spite of washing, because without our knowledge, like they will not tell us that it's not just the IUI that we have done. They would have tried on their own also, and she might have contracted, but ultimately the blame goes to IUI. That's one thing. The second thing is that the cryo cans where we freeze the semen sample, that has to be entirely different.
Pankaj sir, are you there?
Yes, I'm listening, and very good discussion. Thank you.
Sir, tell us if you want to give any inputs, because I think this is our last question, and Dr. Sonu, if any other questions we can discuss. Sir, give your inputs.
No, already well covered, because there is no, because I am not very much experienced with this HIV positive semen IUI. We do ICSI with this, and with the caveat that I can't be 100% that it cannot be transmitted.
ICSI, you are doing so for these patients?
Yes, we did. Yes.
How many patients, sir? Total?
3. Abhi tak 3.
3, and they all are wives are negative. How many years?
Ab itna yaad nahi hai. I don't know. But
I have done IUI for 4 patients in the last 7-8 years.
Okay.
So, and IVF actually for quite a few patients, but there were other factors also for ICSI. But IUI when the semen was normal, but the patients were on HRT and HIV positive with a low.
So pardon me.
So we have done for those after counseling and taking consent from the patient, explaining to them, but the wives are negative.
And pardon me if I'm wrong, we have evidences that the human papilloma virus and HIV virus, they have been spotted on the spermatozoas. It's basically a CD4 specialist virus, but then there are case reports where, HIV virus and human papilloma virus, the cervical cancer virus, has been spotted on the spermatozoas and not on the cells.
No, but we have to explain to the patient that the incidence of transmitting the infection is less than 2%.
Yes, then yes, it is very rare. It is very rare. It is not that common with ICSI, obviously.
So only after that, when the patient agrees, okay, that I'm ready for this, then we do it.
Dr. Sarabjit, please clear my doubt. Where does the HIV virus sit on the? Does it sit on the sperm? Like
no idea, ma'am. No idea, ma'am. Just this thing.
No. Does it get attached to the sperm, or is it on the leukocyte?
ICSI, while I was preparing, I just was wondering how would ICSI actually do the transmission? Why we are not 100%? Why cannot say 100% that ICSI is not going to give any HIV? But through that, I came to know that HIV has been spotted on the spermatozoa, maybe on the tail or head. I don't know.
They say it piggybacks on the sperm.
Yes.
That's why we should have that condition with us, that it is not 100% that we are able to prevent that transfer. That is there in literature.
Okay. And probably the husband will be on the combination of monitoring CD4 count plus on ART and all that goes on side by side.
Even in the cryocans, ma'am, you said that even in the cryocans, the temperature is so low actually for any virus to survive in the cryocans, even if you're using the open system, and even if it gets accidentally mixed, which should not happen. Even if it is going to get accidentally mixed. So I don't suppose HIV has any chance to survive in that minus close to 200 degrees of temperature. But yes, there should be a separate cans and separate pickup units, separate IVF labs.
Together. Yeah.
So I think we're almost through with the questions. Dr. Rekha, we will request everyone to vote and support Dr. Rekha.
Thank you so much, madam.
Request for votes to all the audience.
Yeah, I'm requesting the president and the secretary, Rewari Society, and also the other societies, that I'm contesting for the post of FOXY Chairperson Clinical Research Committee. I'm Rekha Rajendra Kumar, working for FOXY for more than 10 years, for my local society for working for more than 15 years. So requesting through this platform, Dr. Seema has given me a wonderful platform and opportunity to request with all of you. Please vote for me. Thank you.
Hello. So Dr. Priya, have you joined? Priya was stuck in the traffic. If Priya has joined. So we really wish to thank all our participants, our all-rounder Dipankar sir, Dr. Sarabjit. It was really nice meeting you. And Dr. Sunita Chandra, Dr. Rekha, our very own Dr. Sonu, and Ankit ji, Dr. Deepika. Thank you so much, Dr. Surekha, for.
Seema,
Yes,
hello.
sir.
Are we, I'm just interrupting, are we doing from your side collectively to give good suggestions for this new ART rules?
Yes, yes, we're doing.
Yes, sir. Things are now out of our hands. We are waiting and watching. That is how we did for PNDT. Same we have done for this. I feel, if we are vocal, we should be heard. We are vocal only on webinar platforms or other, but when it comes to justice for us, we are all dumb.
No, like Dr.
Sarabjit was saying something. I think we all have to give collective.
We have posted the link. We have posted the link, in our respective groups. We have requested everybody at least to, give some input so that they can go through, their points.
Don't you think it's too late, Dr. Sarabjit?
It's too late. It's
No,
too
no,
late.
no.
It will not help. It will not do any good.
At least,
No, but
it's a paper fight only. We cannot fight like the farmers. When IVF, especially, we cannot go and sit over the daily border and close our IVF units. But at least we can do, some sort of at least resistance we can show so that they come.
Our leaders had no say. Actually, leaders should not have been the part of this very rule, actually. And now it is totally irreparable, sir. Whatever the link we post, whatever we sign in, it is not going to help. And it is going to be very bad, actually.
Madam, the dates have not closed, and at least though we have a very bleak hope, let us, when it is whatever is in our hands, why not? I have already posted my opinion in the whatever mail. So the same one which has been getting circulated, why cannot we post like as much as possible? I feel the government has from their side given the opportunity. That is why for us to tell something. Otherwise, they would not have sent this option at all. Give your opinion. It would have been 100% totally one-sided and would have been sealed off. But now, since having got the opportunity, maybe it's a 0.1%, let all of us put our at least opinion. And also I feel we should make our patients also to write the opinion, forward this whatever link we have got to the patient, because it is everybody can voice. It is not only the IVF specialist has to voice.
Yes,
because there's a surrogate part, the donor part, everybody is involved. As a patient also, they have a lot of saying and can do something. This is what I feel.
I don't know who had made and who were the opinion makers of making this rule. Nobody knows. I don't know whether you people know it or not.
No, sir. No. Actually, it was being discussed for the past 2-3 years.
Yes.
If you go to the Rajya Sabha website, the opinion number 139 is there. You can download the complete opinion, and you'll be surprised to know some of people sitting right close to you might be there in the Rajya Sabha meeting. They have held quite a lot of meetings actually, and that meeting has been held with each and every one of us. The representatives were there from the IFS, from the ISAR, but unfortunately, as I told you, we are not that resistant kind of creatures, the doctors. Okay, what we can do is we can go and humbly ask them that this point is not actually valid, it's not practical, let's change it. But putting that foot down, they have tried their best. I mean, our leaders. But then it is, that kind of, I would say we are doctors and therefore we can do it in this way only. We cannot go and, take our, battle like if our farmers did. They still are doing their leaders. I am in close contact with few of those.
So you
we
are
doing it. But
so you are on
no, I was not in the opinion.
No,
opinion has been taken.
You are in the opinion that these rules has been made by some non-doctors.
Rule has been made by the government, the joint health secretaries and all, everybody. They have taken the opinion of every IVF specialist representing right from the Kashmir to Kanyakumari to Gujarat to Assam. Everybody has been involved. The AIMS people, the CMC people, the army people, the government people, the private practitioner, everybody has, has been taken into that particular consideration. But then, they gave their points. They still are doing it. But unfortunately, they were not completely heard, I would say. They were partially heard.
ये 5 लाख का किसने बोला होगा? 5 लाख क्यों ले रहे हैं? क्या करेंगे?
5 लाख की फिगर सर मुझे भी नहीं, आई डोंट नो फ्रॉम दिस मैजिक नंबर केम, पता चला है कि 7 लाख तो मेडिकल कॉलेज खोलने के लिए है जस्ट. So it is better not to open an IVF, rather to go for a register for
So they think that
medical
IVF
college.
centers, they earn so much that this is just a minimal thing for them.
Exactly.
1 लाख रुपए सालाना आपको वहां दान करना पड़ेगा.
Done, exactly.
It is better to unite together and make conglomerate so that we can also become Shark Tanks.
I wish we can, sir.
I wish, yeah, exactly.
Somehow.
Chalo, okay, bye.
Bye, sir.
Thank you so much, everyone. It was a wonderful thing. Yeah, thank you, Jagsonpal. Thank you, Dr. Deepika. And thank you so much, Sarabji and Dr. Rekha.
Thank
it was
you.
Indeed a very interactive session.
Thank you, Ankit ji. Thank you, Dr. Sonu
Thank you,
and Dr. Sarabjit. We shall meet again, Dr. Rekha.
Yeah. Thank you, Dr. Seema. Thank you, Dr. Sonu and
Okay.
Jagsonpal. Thanks, my
Bye.
co-chair,
best,
Dr.
Dr. Rekha.
Sarabjit.
Yeah,
Thank
bye.
you. Thank you, ma'am. Thank you so
Thank
much.
you all the
Bye.
participants and attendees also.
Yeah.
Yeah, thank you.
Good luck to all of you. Bye.